Assalamu alaikum. Here we are again with another transurethral resection of the prostate. Here you can see the median lobe, and the patient is 62 years, and there is a stent placed in him. The reason for the stent was the right-sided percutaneous nephrolithotomy performed 4 weeks back, and during the Cystoscopy and ureteric catheterization, we found that the patient was having a median lobe, so he needed a resection. So we decided and planned that after the PCNL, when we are performing removal of the DJ stent, we will also perform a transurethral resection of the prostate. So here you can see we have started with the median lobe, as previously mentioned in my previous transurethral resection as well. So the particular thing about this patient is that this patient has been long been a patient of ulcerative colitis, and he by the end he ended up in a total colectomy. So he is now having a permanent ileostomy, and he's having despite the normal uric acid levels in the urine as well as in the blood, he is forming this ureteric stones, the uric acid stones. So the particular thing about this patient was that while we were performing transurethral resection, we found that there was since the stretch on the trigone that was relieved after resection of the median lobe, a ureteric stone, it came into the intramural portion of the ureter. And then we were thinking what to do, whether to perform a ureteroscopy, but we tried a very which is not shown in the books somewhere, but we tried a method and it was successful. We will see that by the end of the procedure. So the indication in him was this median lobe with recurrent urinary tract infections, as well as recurrent episodes of retention as well. But we also thought that this resection, as you saw, that there were a lot of uric acid stones in the bladder. There were some incrustations within 4 weeks on the DJ stent as well. So those episodes of retention may have been due to the stones coming into the urethra. But anyways, he needed a wide prostatic urethra, so that if these small stones come, so he will be able to pass them per urethral. His age is around 62, but he is physically very much fit patient. So the median lobe is resected, as is always my preferred method. I resect the median lobe half, and then I start resecting the right lateral lobe from 7 o'clock to 11 o'clock, and then I resect the left lobe from 5 o'clock to 1 o'clock, and then I see if the anterior lobe needs resection or not. But in 90% of the cases, I do not resect the anterior lobe because it is not contributing to the obstruction. So that is my way of doing things, and I always try to preserve the bladder neck, whether the patient is sexually active or not. The reason for this is that some bit of continence is being contributed by the internal urethral sphincter. So bladder neck is usually not contributing to the obstruction. That's why I do not try to resect that. But in very old age or in a very huge prostate, sometimes I do resect the lower portion of the bladder neck. Here you can see that there is prostate all around. So once the circular fibers are reached, here you can see the circular fibers, then I stop resecting any further. The reason for that is that one is retrograde ejaculation, and the other is bladder neck stenosis, and bladder neck stenosis is a very difficult thing to treat. So prevention is always better than cure. So try to prevent it at this stage by not resecting the bladder neck. So this is what is being done now. So moderate to severe lower urinary tract symptoms, ineffective alpha blockade, refractory urinary retention, back pressure azotemia, and some other complications because of the straining at micturition, like hernia formation, hemorrhoids, bladder stone formation, recurrent urinary tract infections. All these are indications for surgical intervention in an enlarged prostate with bladder outlet obstruction. The choice of surgery depends on many factors. However, till date, transurethral resection of the prostate with monopolar and bipolar is the gold standard for resection of the prostate, and the reason for that is the cost effectiveness. Of course, laser may be better in some aspects, but the cost effectiveness of transurethral resection with a monopolar diathermy is so far the most cost effective procedure. Here you can see the capsular fibers, so it marks our limit to resection. So we will not be trying to resect any further. And then after seeing all the cavity coagulating the large spurting vessels, we found that the procedure is beautiful. And then what happens is the same, that I coagulate the bladder neck minimally. I do not use the diathermy spurts more than 1 or 2 seconds. You can use it up to 3 seconds, but prolonged use of diathermy can lead to charring, and that charring can lead to infection, and also that charring can lead to irritative lower urinary tract symptoms after the catheter removal. So I do the minimum coagulation of the prostatic cavity. So once we were done with the coagulation of the cavity, what happened, luckily, that we visited the bladder to see what's going inside the bladder, and we found that there was a bulge in the intramural portion of the ureter on the left side, and that bulge was yellow in color, marking the presence of a uric acid stone. Here you can see that. So I thought that ureteric orifice is near, so I tried to push that, and luckily what happened, I also thought of doing a ureterotomy, but the stone was small, it is rounded, there are no pokes and spikes, and so it is pushed. Here you can see that stone, and I hope you enjoyed the procedure. Thank you very much for watching.